So there are always people on my socials, every time I ask, what do you want to learn on the channel? They always yell, we want to learn the ECG. I really hope you're enjoying these videos, and by the end of this playlist, you should now be at least one step closer to understanding, or at least have a good understanding of basic interpretation of the ECG. We have done the previous videos and I really hope you enjoy those videos. So in this particular video, we're going to look at atrial hypertrophy. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Every week this is on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at atrial hypertrophy. This is part of my ECG bootcamp. If you haven't yet subscribed to the channel, what are you waiting for? Hit the subscribe button, hit the bell notification icon so you never miss on such amazing content every time I post. This is part 7. I released 2 videos the other day. Even today I'm going to release 2 videos for you guys as we are getting closer and closer to the end of this review series on how to interpret the ECG. At the end of this, I will give you a test video where I will bring you a bunch of ECGs and we'll interpret them together. Then as time goes by, we'll be covering different rhythms slowly, and then we get to understand the ECG in much more details. So if you haven't watched part 1 to part 6, pause the video right now, go watch part 1 to part 6. So do not watch this video if you have not watched part 1 to part 6. What are you still waiting for? I'm serious. Go watch part 1 to part 6. If you start off from here, you're going to be so confused. Remember that in our previous videos, we looked at the 7 steps of interpretation of the ECG. Step 1, looking at the patient and ECG details. Step 2, looking at the ECG calibration. Step 3, the general impression of the ECG. Step 4 is rhythm interpretation. Step 5 is the QRS complex assessment, where we look at the axis, cardiac axis. We look at presence of any bundle branch blocks. We look at the RS wave progression. In this particular video, we're going to look at hypertrophy, specifically atrial hypertrophy. I cover right ventricular hypertrophy in the other video that I'm going to post today, and left ventricular hypertrophy, which I will post tomorrow. Then we will end this series of interpretation of the ECG with ischemia and infarction, which I'll post on another day, and that will be indeed what you need to know to understand basic interpretation of the ECG. So keep in mind that the impulse is starting off in the SA node, and remember that the SA node is found in the right atrium. So when the SA node fires, it's going to depolarize the atrium, and this is going to result in contraction of the atrium. Now this is going to result in a characteristic wave that we see on the ECG, which is known as the P wave. So remember that the P wave is going to be smooth and contour. It's going to be one single wave in lead 2 especially. It's most best seen in lead 2 as a single waveform. It can be biphasic in lead V1. This is because in V1 you have the initial first part of the P wave being positive, indicating depolarization of the right atrium. Then the second part, which is going to be a negative deflection, is going to represent depolarization of the left atrium, because remember the SA node is in the right atrium. So when the impulse spreads, it will first spread and depolarize the right atrium, then it will flow to the left atrium. Keep that in mind. So it means that even the sum of these waves is what is going to result in the P wave that is formed. The first 1/3 of the P wave is going to be due to activation of the right atrium. The final 1/3 is going to be due to activation of the left atrium. Then of course the middle 1/3 is a combination of the two. So your P waves are going to be positive in most leads except for lead AVR, and they're going to be monophasic in all the leads except for lead V1. So in lead V1 you have of course the right and the left atrial waves that are in opposite direction. The first wave being positive, indicating the depolarization of the right atrium. Then the second wave is a negative wave, indicating depolarization of the left atrium. I will show you what these look like. So remember that this separation in lead V1 means that we can actually pick out certain pathologies that are affecting specific ventricles. If there's a pathology that's affecting the right ventricle, you see that the first wave of that V1 P wave is going to be abnormal. If there's a problem with the left atrium, there's going to be that second wave being bigger than normal. If there's problem with both atria, there's going to be a problem generally with both waves. So your P wave is a positive deflection, like I said, in all the leads except for lead AVR, which is normal. You should understand this from our very first video. Our duration is less than 0.12 seconds, so that's less than 3 small boxes. So it should be roughly about 2 boxes wide. And our amplitude depends on whether you're looking at the P waves in the limb leads or you're looking at the P waves in the precordial leads. If it's in the limb leads, meaning lead 1, lead 2, lead 3, it must be less than 2.5 squares tall. So it means it must be less than 2.5 millimeters tall. If it's greater than 2.5 millimeters or 2.5 small boxes tall, then we say that these waves are peaked. If it's in the precordial leads, V1 to V6, your P wave must be less than 1.5 millimeters tall. The axis is going to be falling within 0 to positive 75 degrees. So remember that atrial abnormalities are going to be best seen in the inferior leads. That's lead 2, lead 3, and lead AVF. And they can also be seen in lead V1. So the P wave is most prominent in lead 2 especially. So this is what it looks like. So as you can see here, the first 1/3 is going to be due to depolarization of the right atrium. The remaining 1/3 is going to be depolarization of the left atrium. Then of course the middle is going to be a sum of both the left and the right atrium. Then this is what's going to be resulting in your P wave. Remember that your P wave must be equal to less than 2.5 squares. So as you can see, this is 2 squares tall. So it must also not be wider than, of course, your 3 small boxes. So you can see here it's fitting in about 2 small boxes there. So this is a normal P wave. So what really happens in right hypertrophy, which is also referred to as right atrial enlargement or right atrial hypertrophy? So here you're going to see changes in the P wave. Because now there is something that is causing the heart muscle to enlarge on the right side, on the right atrium, it means that it's going to generate a much greater electrical activity. It's going to generate a much greater force. So it means that with this electrical activity that is generated, that is greater, you would expect that the deflection on the ECG is going to be bigger than normal, bigger than usual. So with right atrial enlargement, you're going to be seeing these peaked P waves, which is what we refer to as P pulmonale. They can be seen in lead 1, they can be seen in lead 2, they can be seen in lead 3. So you have these peaked P waves, which are greater than 2.5 millimeters tall, and we can see them mostly in the inferior leads, lead 2, lead 3, lead AVF, best seen in lead 2. Then you also see the peaked P waves more than 1.5 millimeters in lead V1 and V2. So like I said, remember your first part of the P wave is going to show you depolarization of the right atrium, and the last part of your P wave will show you depolarization of the left atrium. So if someone has a right atrial enlargement, they're going to have a high voltage that is going to cause these very tall P waves, and remember that the left atrium is going to depolarize in a normal fashion. And if this left atrium depolarizes in a normal fashion, it means that it cannot conduct this increased voltage that is it's going to be receiving from the right atrium. So there's going to be a sudden drop in the voltage. So this results in the peaking of the P wave, which is what we refer to as our P pulmonale, our peaked P waves. So this is what it normally looks like. Notice this is in lead 2, this is in lead V1. We have a normal positive deflection. This is a normal P wave. And this is in lead AVF, which is a biphasic P wave. So we have this first part here, which is indicating right atrial depolarization. You have this second part here, which is representing left atrial depolarization. Now what happens now in right atrial enlargement? You're going to have, of course, this very tall P wave. You can see that there's a P wave here that is greater than 2.5 small squares in the limb leads, or greater than 1.5 small squares in the chest leads. So here we can see there's this rapid rise in this initial wave. This is due to the increase in voltage because of the right side that has been enlarged, and then there's a sharp decrease in the voltage because it cannot be conducted entirely by the left atrium. So we have these P pulmonale waves, which we see in right atrial enlargement. As you can see here, it's a very sharp and peaked P wave, initial P wave in our biphasic P wave in V1, and of course we have this last part which is normal because the left atrium is normal. So that's what we see in right atrial enlargement. So here's an ECG to show you that, as we can see here, we have very peaked and symmetrical P waves. As you can see, these P waves here are greater than 2.5 millimeters tall in lead 2, are greater than 2.5 millimeters tall in lead 3, and of course in lead AVF here, they're also greater than 2.5 millimeters tall. So this is suggestive of P pulmonale. Then on the other end of the spectrum here, we have V1 and V2. So as you can see here, your P wave here in V1 and V2 are greater than our 1.5. These are greater than our 1.5 millimeters. So as we can already note that our P wave is biphasic. It's much more prominent here if you look at it in your lead V2 actually there. So that's how we're going to be looking at the P wave and assessing the P wave in order to look for any right atrial enlargement. So what are some of the causes of right atrial enlargement? So you must think of conditions that are affecting the lungs. So anything causing pulmonary hypertension. It could be chronic lung disease like a cor pulmonale, a pulmonary embolism, an atrial septal defect, a tricuspid stenosis or a pulmonary valve disease, congenital heart diseases like pulmonary stenosis, tetralogy of Fallot, even primary pulmonary hypertension. So that's with the right axis, or rather right atrial enlargement. You're going to be seeing your P pulmonale, your peaked P waves. Then in terms of left atrial enlargement or left atrial hypertrophy, remember this is anything that is causing pressure or even the volume overload on the left atrium. So this one here is going to be a precursor of the atrial fibrillation, and it's also going to be presenting with changes in the P wave. So now here, remember that your left side has enlarged. In the normal scenario, remember that the right side is going to depolarize first, then the current is going to spread to the left atrium. But in this case, the left atrium is generating a much greater electrical impulse because it has more muscle now, it's under much more stress. So what does this look like on our ECG? You're going to get an ECG that has like two humps. We call this as a bifid P wave. So you're going to get a broad bifid P wave, which is best seen in lead 2. We can also see it in lead 3. We can also see it in our inferior leads. Then of course your P wave is going to enlarge with the terminal negative portion in the biphasic P wave in V1. So remember that negative portion, the second part in V1, is going to be even much deeper than usual. So what's our diagnostic criteria? So we say that they are bifid if they're going to be greater than one small box wide between the two peaks, and then of course if the P wave duration is greater than, total duration is greater than 2.5 squares, then we're going to say that if we see this in lead 2, this is suggestive of a P mitrale. So it looks like an M, if I can say so, like two humps of the P wave. That's going to be a P mitrale. In our V1, you have our biphasic P wave. So the terminal portion, the second part, which is the negative deflection, is going to have a duration that is greater than one small box. And of course, the negative portion is going to be deeper than one small square. So it must be greater than one box wide and one box deep. So we say that then there is some left atrial enlargement. So this is what it looks like. So as you can see here, we have the first hump, which is indicating right atrial depolarization. We have the second hump here, which is indicating left atrial depolarization. And you can see that this is a broad P wave, so greater than your, obviously greater than your one small box. Then in addition to this, we can see that in V1 here we have our biphasic wave. So as you can see, the second wave here is going to be greater than one box wide, and it's going to be greater than one box deep. So if we focus on this on the right here, we have a P mitrale. As we can see here, this is like one, 2, 3 boxes wide. So you can see it's 3 boxes wide already. So it's quite kind of like a broad P wave, and it's the 2 notches. It's a bifid P wave, so we call this as a P mitrale. In terms of the precordial leads, this is in V1. As we can see here, the duration again of your P wave, the second part is greater than 1 box. As you can see, it's 2 boxes, so it's greater than 1 box, and it's slightly greater than 1 box deep. So it's one greater than 1 box wide, slightly greater than 1 box deep. So as you can see, we have the initial positive part, which is normal, but this negative part is abnormal. So this is what you see in V1. Same thing here. Here we have an abnormally deep P wave here. We have a small initial deflection and a very deep one that's greater than 1 millimeter. deep, so greater than 1 small box deep. So this is indicative of left atrial enlargement. What are some of the causes of left atrial enlargement? If it's happening in isolation, it may be due to mitral stenosis. If it's associated with left ventricular hypertrophy, which I will talk about in subsequent videos, it may be seen with systemic hypertension, aortic or mitral stenosis, mitral incompetence, and even hypertrophic cardiomyopathies. Now, sometimes you may get enlargement of both the left and the right atrium. So we have a biatrial enlargement. So it means that you're going to have both the things that are happening in right atrial enlargement as well as the things that are happening in left atrial enlargement. So in addition to this, number one, you're going to have your P waves are going to be bifid to begin with, indicating that there's a P mitrale that's there. So you have your bifid P waves, so your two humps, the initial hump for the right atrial enlargement or right atrial depolarization, the second hump for left atrial depolarization. So that is what we refer to as our P mitrale. And this overall wave is going to be very huge. So it's going to be taller than 2.5 small boxes. So it's going to be peaked, indicating a P pulmonale. And its duration is going to be greater than 3 small boxes. So this is what we see in lead 2. Then in lead V1, we may sometimes see an initial positive deflection that's greater than 1.5 small boxes tall. Then our negative deflection is going to be greater than 1 small box deep, and of course the duration of this negative deflection is going to be greater than 1 small box wide. So you need these criteria to be present for you to say that there is biatrial enlargement. So when you combine the two, you get a positive deflection that is greater than 1.5 millimeters or 1.5 small boxes tall in lead V1 and V2, together with a notched P wave with a duration greater than 3 small boxes, of course, in lead V5 and V6. Then we say that there is biatrial enlargement. So here's an example. Pause the video, write down your answer, use the 7 steps to see if you can work this particular example out. If you don't solve these things, you'll never understand them. And here comes the answer. So again, our 7 steps. The first step is ECG details, which we don't have here. The next step is the calibration. It's of course standard or normal, 1 small box wide, 2 boxes tall. We even have this inscription here, 25 millimeters per second, 1 millivolt is equals to 10 millimeters. So when we look at this ECG very quickly, our general impression that it's moving very fast. The QRS complexes are very close to each other, so it's moving very fast. Ask ourselves, what is the regularity? Is it regular? We check, are there P waves present? So this is our rhythm strip here. So our P wave is present, our QRS complex, our T wave, our P wave, QRS complex, our T wave, P wave, QRS complex, our T wave. So we can already ascertain that this is a regular rhythm. So we can even measure the distance of the RR interval. It's regular there. Then we come and say the P waves are present. If we want to now calculate the rate, we're going to say now, if we look at from here, we have 1, 2 and about a half. Then here we have 1, 2, 3. So we have about 3 boxes here, 3 big boxes. So 300 divided by 3, so roughly at around 100 beats per minute. The P waves are present and they are upright. As we can see, they are upright here in lead 1, they are upright in lead 2, they are upright in lead 3. In AVF, they are inverted, so which is normal. We come and now look at the PR interval. If you count the small squares here, they're going to be normal. We look at our QRS complex. Your QRS complex here is narrow, so you have a narrow QRS complex. When we come now to the cardiac axis, here it's very difficult to actually tell about the cardiac axis, but as we can see, it's like these waves here in lead 1 and lead 2 are overlapping, but we can see that lead 1 is predominantly negative, lead 2 is going to be lead AVF is predominantly positive, so is lead 3. So most likely this is a right axis deviation. We now check if there's any presence of any bundle branch block. We check for lead 1 for any M waves. We don't see those here, though it's very difficult because these waves are very close to each other. We check for V6, there are no M waves. There's no slurring of the S waves in either of these, so there is no bundle branch block. It's very difficult to assess the RS wave progression here, but of course if there's a right axis deviation, it means that lead 1 is already facing downwards. That's a poor RS wave progression. In terms of now hypertrophy, we now check the atria. We check for the P waves in lead 2. We can already see that our P waves in lead 2 here are peaked. So as you can see here, they're going to be more than 2.5 squares tall. So our P waves in lead 2 are going to be peaked. Same thing that's happening in lead 3. In lead V1, we can already see here that also in lead V1, you may have these that are greater than 1.5 boxes tall. So this patient here has a sinus tachycardia at a heart rate of about 100 beats per minute, and they have right atrial enlargement. We shall note also from the next video that I'll talk about in terms of right ventricular hypertrophy that this person also has right ventricular hypertrophy. As we can see, the R waves in V1 are quite tall, so which is usually suggestive of right ventricular hypertrophy, but we haven't yet covered that. Coming now to example 2, you may pause the video and work this out. Remember, if you don't work these examples out, you're not going to get it. And here comes the answer. So, of course, the first thing, the details, this is a male that is 70. So as you can see here, male 70. We don't know when this ECG was done, where it was done. The calibration is standard, so 25 millimeters per second, 10 millimeters is equals to 1 millivolt. One small square, this rectangle here, 2 boxes tall. So the general impression is that you have these ugly morphologies that we can see in this ECG that don't look normal. Our heart rate, or rather, first of all, quick assessment of the regularity. We come and check our P waves, they're present, followed by curious complex. Your P wave followed by curious complex, your P wave followed by curious complex. We can see that for 3 consecutive waves, so that's usually a sinus rhythm. So our rate, we count the boxes there, they're about 18 between the RR intervals, so 1,500 divided by 18 small boxes, roughly around 83 beats per minute. We look now at the rhythm in details. The P waves are present. You can count your PR interval here is going to be constant and it's normal within 3 to 5 small boxes. Your curious complexes are broad, they're greater than 3 small squares. So here you have broad curious complexes. So this should mean something to you. It means that the conduction is either not going through the normal pathway of the heart, or the conduction is starting off from the ventricles. It's more likely that the conduction is going through an abnormal pathway because you have P waves that are present here. We look at our cardiac axis. Lead 1 is facing upwards, lead AVF is facing upwards, lead 2 is facing upwards, so most likely that's a normal axis. We look for any presence of any bundle branch blocks. We look at V1 and V2. As you can see, they are deep S waves that we can see in V1 and V2. We look at V5 and V6. We can see that there's some notching of V5 here, and there's some notching of V6. That's usually a feature of left bundle branch block. Though remember that in left bundle branch block, you do expect some sort of axis deviation. So it means that there may be another problem that may be there in this particular patient. We look at our RS wave progression. Lead 1 should be facing upwards. Lead 2 should be facing upwards. Lead 3 should be facing upwards, but it's not. Lead AVL facing upwards, it is. AVF facing upwards, it is. Lead 1 and lead 2 should be facing downwards. V5 and V6 should be facing upwards. So actually it's a normal, because remember the precordial leads are the ones that matter most. So it's a normal RS wave progression. Then in terms of hypertrophy, we now look at the atria, we look at the P waves. So if you look at your P waves very closely, especially the P waves that are in lead 2, they are actually quite tall and they're going to be quite pointed here. And we can even see this especially in lead V1, where you have this biphasic P wave that can be seen in V1, though it's normal. I just wanted to point out that you have this biphasic P wave. We can also see that there is some slurring or rather sloping of the ST segment here, but I'm not going to talk about that right now. So this patient here, of course, what's our interpretation? They have a sinus rhythm at roughly around 83 beats per minute. They have features of left bundle branch block. They have features of left atrial enlargement. And if we notice here at this 8th beat here, so as you can see, this 8th beat on the rhythm strip, there's something that's going on here. So this is what is known as a premature ventricular contraction. So you can actually have a chance to actually see this on the ECG. So you can see that there's a wide complex beat that's not going to be associated with a P wave in this particular premature ventricular contraction compared to the other wide curious complexes that have a beat in it. So that's the example. Coming to the next example, which is example 3. I want you to pause the video, write down your answer, scream it at the screen, and work it out. And here comes the answer. So as you can see again, we start with our ECG details, the calibration, which is standard. Our general impression is that there is this ugly morphologies that are broad on this ECG. We can look at the rhythm here. It's going to be irregularly irregular. The distance between this to this, this to this, this to this is not the same. Then if it's irregular, it means that we have to count now 30 squares from the beginning to about somewhere there, 30 squares, so that we can determine your rate using our method. So we count about 30 squares, and we can see in this 30 squares there are about 6 QRS complexes. So it's 6 times 10, which is about 60. So that's the ventricular rate, roughly around 60 beats per minute. We look at our P waves. Our P waves are present in our lead 2. We can see that our P waves are present, followed by QRS complex. Each P wave is married to a QRS complex. There's a P wave here, QRS complex, a P wave, a QRS complex there. The PR interval is quite prolonged, but I will come to that. Now, the QRS complexes are broad. As you can see, the QRS complexes are broad, and when we come to assessment of the QRS complex in terms of axis deviation, lead 1 is facing upwards, lead 3 is facing downwards, lead AVF is facing downwards, lead 2 is facing downwards, so that's a significant left axis deviation. We come to presence of any bundle branch blocks. There is, of course, deep S waves in V1, V2, as well as V3. There is some notching that we can see of the QRS complex in lead V5 and V6. This is suggestive of a left bundle branch block. The RS wave progression, we can see this is supposed to be facing upwards, but it's downwards. This should be facing upwards. This should be facing upwards, so already there's a poor RS wave progression in this lead. We come now to the presence of any hypertrophy. We look at the P waves, especially in lead 2. We can see that here, what's happening here, there's these 2 humps that we can see, and this is great. If you actually, this was a better picture, it's much greater than, I can say, 3 boxes wide. So this here is what is known as your, of course, your biphase P waves. And we also have this biphasic P waves that we can see in V1. So this is actually a feature of a person that had left bundle branch block, and this particular patient had left atrial enlargement. I really hope you enjoyed this video on the ECG. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.